Welcome to the Wyoming Department of Health Early Intervention and Education Program Training Series. My name is Christine Demers and I am the Part C Coordinator. I would like to introduce today Jennifer Davis, who is helping us with our early intervention eligibility training, along with Sarah Nicholas. Jennifer Davis is a physical therapist, and Sarah Nicholas is an occupational therapist. Both have a lot of experience in the early intervention program, working for child development centers in Wyoming, and they will present to you today Wyoming Part C, Birth Through 2, Follow the Path, and this is the story of eligibility. Thank you. Sarah Nicholas.
Good morning. Today we're going to talk about determining initial eligibility in Wyoming, identifying children birth through 2, going through the evaluation process, and then beginning the individual family service plans. When we're recording this, it's March, and I'm looking forward to summer. Winter is fading, and I can't wait for campfire stories around some marshmallows. When I think about campfire stories, I think about oral language being passed down, a bit different than written language. Written stories are more detailed and more accurate. And when we talk about the individualized family service plan, it really needs to be a detailed, accurate account of what is going on inside of a family and with a child. It can't quite be the campfire story, something that the parent told you, but something that's well documented. IFSPs require written documentation, often everything. You know the story, and in a small town, but the file does not tell the story. It needs to be the written record. We can tell the child's unique story with an IFSP using rich documentation. When we tell the story of assessment through the IFSP journey, we're learning how to tell the story of assessment with a file that tells the story and how the CDC can really meet the needs of the child and family. We do that through child find, through screening, initial eligibility, determining the concerns of a parent or guardian, and is that a match with the assessment that we have, and determining medical needs, and finally compiling that into the IFSP. Assessment is really the process of getting to know a child. Assessment is the evaluation or estimation of the nature, quality, and ability of someone or something. Authentic assessment is what we're looking for with infants and toddlers. You look for authentic assessment as they participate in familiar daily activities, their routines and interactions, and that produces the most valuable information for your assessment. To every extent possible, assessment should allow for the observation of infants and toddlers to engage in spontaneous behaviors in a familiar setting and with familiar people. Obviously, bringing that child into a child development center with unfamiliar people and within unfamiliar surroundings can often produce it is not an authentic assessment. Early childhood professionals should gather all the information they need and know ahead of time how they will use all the information that they collect. Assessment is really getting to know kids. Some assessment instruments and procedures are definitely better than others. We know this by experience over the years in our child development centers. We all have our favorite tools that we use. But of primary importance is the quality of the information that we gather and the decisions made as the result of assessment. Ultimately, whatever assessments we conduct should benefit the children, families, and programs that we serve. Self-monitoring of your program can ensure that assessments are well chosen for each child. When we self-monitor, our own program, you can use a monitoring form that Christine often uses when she comes to your facility. You could also use peer-to-peer self-assessments. You can videotape yourself or videotape therapy, even videotape a family service coordinator in IFST meeting. This can be a really powerful tool to self-teach and see how you're working with families. You can break bad habits by reviewing these together as a team and use in staff meetings or reflective time with a supervisor.
Good morning. This is Jennifer Davis, and I am going to talk about the different methods of assessment. So as we start to look at how we assess children, as Sarah had mentioned, we want to be very sure that we are getting all of the information necessary to complete this by talking with parents and by using assessments. So methods of assessments refer to your actual procedure of how you're going to get that information. So more formal methods and procedures such as standardized testing, this is how you will determine eligibility. Because each early development is complex and dynamic, the most effective assessment procedures are characterized by a combination of methods and sources of that information. So one example would be you're using a standardized test, but then you also would be getting information from the parents that can't be derived from your assessment tool, such as with an RBI, a routines-based interview with a parent. And really understanding what that means of getting all of the critical information from those parents who deal with the child on a daily basis that affect their routines, that affect their behaviors and their temperament. The purpose of assessments can look at a variety of different things, such as screening, which is done through your 1 Before 2 campaign, and that is really to determine where a child is at developmentally and if there is a need for further assessment. Diagnostic testing is looking at the child's strengths and areas of need through development and their behavior. You can look at the severity or the nature of their special needs. This is what you would need to use to determine eligibility. This is using your tools such as your Battelle, your Bailey, your Peabody. Those are the standardized tools that you're using for this particular area. Instructional is really to determine more information and support looking at the child's learning and development, such as setting goals, looking at the curriculum that you're going to use to accomplish that. In this training, our main focus is going to be on diagnostic and instructional. Since we're going to be talking about eligibility, we won't be referring much to the screening assessment. However, you will continue to use your screening assessment to determine if there is a need for further testing to determine eligibility. This is really designed to look at identifying potential problems, and you want an instrument that you can use quickly and easily. And the screening tools are really to help you determine if you need to move to the next step. It does not determine eligibility for services in the state of Wyoming. Also, screening tools are meant to be used on regular intervals. We don't want to leave a parent with the misconception that this is a one-time event. We need to ensure that we're educating them, that they need to have continual screening of their child, because there is a lot that changes in development from the very first few days of life through your child in this particular program in Part C until age of 3. So really ensure that as you're screening, determine with your families that they need to have regular checkups. Screening assessments are really developed to really get at looking at the technical information to demonstrate reliability and validity. These should really only take you 30 minutes or less to administer. These really should have a comprehensive administration and scoring instruction, and they should be from a reliable publishing company. So some are the ASQ, the Battelle, Developmental Inventory Screening Test, and Developmental Indicators for Assessment, the DIAL, are some examples of some screening tools that we use in Wyoming. The Department of Health through Christine, and with the Maternal Child Health Department through Charla Ricciardi, you can receive a free ASQ3 and an ASQ SE kit if you do not have one in your facility, and there is also training available for that. So if you don't have a tool that you're currently using or you want an updated tool, that is available for free to you as a Child Development Center. When we look at now the specifics of Part C, we really want to make sure that you have your Part C hat on and that this is not confused with any Part B eligibility. So when we look at diagnostic assessment, it is a thorough and comprehensive assessment of early development, and really the purpose of identifying a specific delay, disability, or specific skill deficits that determine your eligibility for children birth until the age of 3. Diagnostic assessments are conducted by trained professionals using specific standardized tools, and you need to be really clear which tool you're using, who is eligible to be a deliverer of your particular tool. Some of them have very specific requirements. When you're using them to determine eligibility and early intervention, the diagnostic standardized assessment is the formal procedure that is governed by federal and state law. These are comprehensive diagnostic instruments, and they are norm referenced. They are required in Wyoming to determine if an infant or toddler has a developmental delay or disability and is eligible and in need of services. So in Wyoming, they need to have a 25% delay and or a negative 1.50 Z-score in one area of development in order to be eligible for services. Diagnostic assessment results for birth to the age of 3 are present as a standardized score that compares your child's performance to those that were norm referenced for the test for the same age peers as your child. And again, looking at each individual assessment, whether they correct for prematurity and knowing what the requirements are for deciding the chronological age of that child based on premature birth. So you need to make sure that you're looking at that in order for that to align with your peer grouping for your norm reference test. When you're looking at the diagnostic assessment, you are able to utilize those to calculate your percent delay, which is your mental age divided by your chronological age times 100 gives you your percent delay. Your percentile scores should be reported with standardized scores, your Z-scores, and or age equivalents, and percent delay in addition to your descriptive developmental information. So you really need to be ensuring that your scores are aligning with how you are giving your descriptive information and your narrative of your report for the child. One reporting method alone is not useful in the development of an IFSP. So again, really ensuring that you're looking at the RBI information, that you're looking at your standardized tool, and that you're also looking at the quality of the interaction that you're having with that child.
Jen, I'll interrupt here to say that when you determine when a child is eligible for services, you need to determine in every area of development the standard deviation, which is the negative 1.50 or greater, and you need to calculate a percent delay in each area. This will help to ensure that you are correctly identifying that that child is indeed eligible for services.
So when we further look at the diagnostic testing, you want to look at the individual subtest scores. However, those are not to be used for determining eligibility. You need to look at each domain. So when you're reporting the scores, the total developmental area, the total domain scores are required for determining the eligibility. What Sarah had just expressed by looking at your percent delay, your Z-score in that area of development is what you need to look at, not the individuals of breaking out like visual motor skills or locomotor skills. Articulation is not a choice in Part C. And that is because children are still learning and norms are not very well established below the age of 2. However, if there is some severe apraxia, then you can do an RTIC test below the age of 3, as long as it is an adjunct to the assessment that you are already performing. And you need to give a significant clinical description of that. So you need to use your informed clinical opinion as you're utilizing an articulation test to say why you felt that was necessary and what the results of that are. There are many assessments that are standardized also under the age of 6 months of age. So in Wyoming, you do not need to wait until 6 months of age to do a formal assessment on a child. It is suggested, though, if you are going to evaluate under the age of 6 months, that you are going to need to do that again at some point, because there is a lot of growth and change that happens before the age of 3. So again, be sure that you are looking at evaluating these children under the age of 6 months of age. There are several good tools to use. There is the test of infant motor performance, better known as the TIMP, the infant motor performance, which is the IMP, the clinical newborn behavioral assessment scale, and the Bailey scales of infant development. These are all tools that you can utilize to evaluate and get eligibility determination for those children under 6 months of age. So when we look at a quick note of your formal procedure, and we mentioned this earlier, you need to be sure that you're calculating prematurity if it applies to the child that you're evaluating. And again, knowing what the requirements for that are on the specific tool that you're using. Most of the tools allow you to adjust for prematurity up to 24 months of age. And you also need to make sure not all assessments require you to calculate for prematurity. So you need to be sure that if you're utilizing one tool that requires it and another that does not, you need to be very clear on why that is happening and write that into your narrative component of your evaluation. It is really important that you explain that to parents so that they really are clear why you're not adjusting for premature age. This can be a very confusing point for them, especially as they follow up with medical providers. If they're not correcting for premature age and you are, that can really be very confusing for parents and really not give an accurate picture of that child's development. Also on your testing protocol, you need to ensure that you have your full name and credentials on the test protocol. You need to have the full name and date of birth of the child on the testing protocol. And the test protocol must have a date on it, the date that you are actually performing the test. And you are not allowed to use pencil, sticky notes, or whiteout on your formal diagnostic testing protocol. This is part of the medical record. It needs to be filled out in pen, and no whiteout is allowed on that. Then as we move on at looking at the developmental instruments, they all should be norm referenced. You have a list of approved protocols that you can use in the state of Wyoming. You need to make sure that the testing protocol that you're using is one of the accepted for the state. And you also need to be sure that you're looking at a norm reference evaluation so that you know that they have been compared against individual scores of normed or preset criteria. All diagnostic instruments should be standardized in their administration and scoring. Diagnostic instruments must have data available to document reliability and validity and or data to support the cutoff scores for eligibility. So that means that you have a ceiling and a bottom score using assessment. So you need to find that in your test protocol to know where you're beginning and be sure that you're following that appropriately. Also, many test protocols required qualified personnel to conduct them, so you need to be sure through the instructions of the testing protocol that you are following with that about who can administer and score it and interpret the assessment. You should have at least 2 examiners
from different disciplines. It is okay to utilize a family service coordinator as one of the examiners as long as their credentials are okay with the assessment given. So again, ensuring that you know what the requirements are of the specific protocol you're using. And then you need to use the most highly qualified personnel in the particular area to administer parts of the evaluation. So for instance, if you have an OT present but not a PT, the OT should evaluate both gross motor and fine motor skills. Diagnostic procedures must be culturally and linguistically relevant. So again, they need to be conducted in the child's native language. And so if you have a family that is not English speaking, you need to ensure that you are providing the testing materials in their native language so that you get an accurate representation of that. You also need to be very sensitive to cultural issues. For instance, oftentimes for young children there is mirror play or mirror questions in testing protocols, and that may not be culturally relevant for a Native American family. So you really need to be clear who you're testing and what you're testing, that it is relevant how you're utilizing the protocol. There can also be challenges to administering a diagnostic assessment. So infants and toddlers are very variable from 1 minute to the next. So you need to be sure that as you're evaluating these children that you're mindful of that. Also be mindful that if a child is coming to you for a full assessment after a screening, that sometimes a screening may have had a poor representation for the child. They might have been tired. They might have not been in a typical situation or environment for them. You may have asked them to do some things that they've never experienced before. So they might score low, but then when you go in to do your comprehensive assessment, things look a little bit different, which is very typical for young children to be very variable depending on a variety of different things. So really ensuring that you give the child the best possible scenario when evaluating them. If you can do it in their own environment, that is best. If you can do it at a time after they're rested and after they're fed, that is ideally when you should do your testing. However, we know that's not always possible and that things change throughout a child's day. But you need to really be sure that you're looking at, will the potential benefits of these special services outweigh the disadvantages of a more complex schedule and the stigma of being labeled? So again, ensuring that this child has the best chance possible during the evaluation to perform at their best ability. Also, you want to make sure that you're giving directions in a way that they understand them, which goes back also to making sure that it's in their native language and that it's culturally relevant for them. And then also giving the child time for the assessment, and don't rush through the items. Sometimes children need a little bit more time to process that information, and that we also need to be mindful that sometimes these children may have not been exposed to the items that you're utilizing for testing. And again, I would add one thing to that, is that when we do diagnostic assessments and we come up with a score that meets eligibility, we can't undo a score that meets eligibility. When a child meets that eligibility, we can't then not offer services to that family and child. So some of the other challenges that can come with the administration of a diagnostic tool is that you will also need to use your professional judgment. That is going to supplement your test results by conducting your interview, utilizing your RBI information, and also just observing from a trained professional of what this child is experiencing, because this can lead to different conclusions about the nature and severity of the developmental problems. As trained professionals, you know what to look for in a quality of movement that may not always be
reflective in a standardized testing tool. So you really need to be mindful that you're capturing all of that information into your narrative component of your assessment. And when you look at diagnostic assessments, you're really looking at answering some of these questions is, what is the nature and severity of the problem? And is this individual eligible for special services? That is what you determine with a diagnostic assessment. It is able to give you your standardized scores, your percentiles that you can use for eligibility. They are norm referenced, so that compares the child's performance to a representation of children that are the same age. These are often administered by healthcare and educational professionals, often the specialist in your program. And the administration is, these give you very specific information on the suspected delay. It is this comprehensive assessment that is required to determine your eligibility in Wyoming. We also know that these have been norm tested and they are reliable and they have validity to them. And you also then are able to ensure that you're getting an instrument that is looking at children of the same age for comparison. Some of your sample diagnostic assessments that are eligible to be used in the state of Wyoming is the Battelle Developmental Inventory, the 2nd edition, the Bailey Scales of Infant Development, your 3rd edition, the Kaufman Assessment Battery for Children, the Peabody Developmental Motor Scale, 2nd edition, and the Preschool Language Scale. These are just some of the examples of the diagnostic assessments that are available to you to utilize in the state of Wyoming. And then lastly, as we look at assessment, we want to be sure that because early development is complex and dynamic, the most effective assessment procedures are characterized by a combination of methods and sources of information. So again, be very mindful as trained professionals. You are critical at not only using a diagnostic tool, but also then utilizing your professional opinion and your judgment to determine this child's eligibility and determining the severity that may or may not be picked up on your assessment tool.
This is Sarah again. Next, we're going to talk specifically about what determines that a child is eligible in Wyoming for services. The program that governs early intervention in Wyoming is the Early Intervention and Education Program, birth through 2. The director is Christine Demers, who's here today. The regulatory authority would be the IDEA, Individuals with Disabilities Education Act, as well as the state of Wyoming's Part C approved application. The criteria in the state of Wyoming is, again, to have a 25% delay or negative 1.5 standard deviation below the mean in one or more areas of development. Or you can use clinician opinion, or the child can have a diagnosed physical or mental condition such as Down syndrome that is a high probability resulting in delay. So what does it mean to be eligible for services? We need to really strike our language of qualify out, because we're making a child eligible. They don't qualify in a certain area, but rather we determine eligibility by meeting one of those areas just mentioned. Once we get our ticket punched, you can ride any ride at the carnival. What that means is if a child is eligible in one area of development, then they are eligible to receive any of the services provided in the Part C services at your center. And that is the basis for beginning your IFSP, for writing your goals and objectives, and for serving the family. So if the child's only area of service that they meet the need is in gross motor, their eligibility says that they can receive services from any provider. When we look specifically at the IFSP eligibility determination page, and oftentimes this is the family service coordinator who's completing this part, you need to choose number 1, number 2, or number 3. Check your page to make sure that you've only chosen 1, which is the right one, meaning that the child meets an area either negative 1.50 or 25% delay, or it's clinical opinion, or the child has a diagnosed condition. That category must match the demographic page in C's, and this helps with state tracking to correctly identify children in which category. And that's important because we know that number 1 and number 2 would mean a category of developmental delay, and a number 2 would be a medical diagnosis. This statistically helps our state agency. The Part C definition, again, is 1.5 standard deviations below the mean or 25% delay in one of the following areas: fine motor, gross motor, receptive language, expressive language, cognitive skill, social emotional skill, and self-help adaptive skill. As Jennifer mentioned earlier, we don't further break that down into subcategories, but rather look at the category as a whole. When we look at medical diagnosis and determining eligibility, we need to ensure, first, that there is a release of information present in the child's file, signed by the parent or guardian, for each medical facility that has relevant medical information that your center needs. Examples might include EDI, the local hospital or a tertiary care hospital, medical clinic or specialist, a primary care provider, an audiologist, a private therapist, WIC, anyone who might have information regarding that child. And you should obtain copies of pertinent medical records to support the child's diagnosis or determination. Current copies must be present, so if the child enters at birth, you should look to update those, that child's file yearly. And if the child's condition changes, such as a surgery performed or a hospitalization, please go ahead and request relevant medical records. If a child is determined eligible based on a medical diagnosis, then absolutely medical file should be updated in the IFSP. However, if the child is determined eligible by clinical opinion or by a standardized testing, but that medical file may still have pertinent information for that child, go ahead and request it so that they can make the IFSP a complete picture. Testing procedures for instructional purposes are to determine developmental needs, not for eligibility determination. Wyoming, as far as medical diagnoses go for determining eligibility, Wyoming does not use an approved list of diagnoses, but rather this is left, the determination is left to a practitioner's judgment in conjunction with the medical provider. So go ahead and visit with the medical provider to, if you're not versed in that disorder or disease. There must be a high degree of probability that the child, that the diagnosis will result in developmental delay. Examples of this, and obviously this is not a complete list, would be Down syndrome, cerebral palsy, a hearing loss, or maybe Rett syndrome. Colorado does contain a database of state-approved diagnoses. If you're unsure about a rare disorder or a disorder that you haven't encountered before, sometimes it's a good idea to look here at the Colorado database to see what their determination is. Oftentimes they even have an explanation about why it was included in theirs or not. And then as a team, you can decide if you feel that meets the criteria in your center for medical diagnoses. There are many medical diagnoses which may impact development, although to a lesser probability than those other known conditions. Examples of these include, but are not limited to, brachial plexus palsy, hand deformity, limb deformity, torticollis, and plagiocephaly. These conditions in and of themselves may not point towards eligibility for early intervention. However, there may be other circumstances in that infant or toddler's life, such as their health status, their family situation, or additional developmental delay, that may influence the course of their development. When development concerns exist concurrent with the diagnosed conditions, the child's evaluation team should then determine eligibility. Appropriate community referral is absolutely imperative, especially with this population of children. Know your community partners. Community partners can include maybe a therapist at a local hospital, private therapists, early Head Start, etc. A child may have a referral from a physician for an above condition, but that does not necessarily mean that the child is then eligible to receive services. The child needs to be evaluated at your CDC using standardized assessment. If the child has no other limiting factors, that child should be referred to a community resource. Also, education of your local providers, including physicians, to help them understand what determines eligibility in Wyoming. Coming back around to torticollis, because we see this quite frequently in our centers where a child is determined eligible only with the diagnosis on a medical diagnosis of torticollis. But in fact, as just stated before, this really is probably a lesser probability of determining developmental delay. Torticollis is viewed as a medical condition for which there's really wide variability in clinical expression from mild to severe. Torticollis is not routinely considered a condition that has a high probability of resulting in DD, and children with this condition are not automatically eligible for the IFSP. However, if you feel like the torticollis is severe and has obviously other impacting conditions in the child's life, then that needs to be justified within the IFSP. If the primary health care provider has a concern and has a referral or prescription for service, know that you need to educate that, again, you need to educate that provider on what is determined eligible for services in their state, so that you can help determine appropriate referral to your services. Last but not least is clinical opinion. Clinical opinion, when used to determine eligibility, must be rich in description, listing potential impacts on a child's development. Please include information from the child's medical chart when appropriate, and also a good discussion of items such as quality of movement, maybe time spent in a NICU or special care nursery, the use of an NG tube, a sensory disorder, feeding problems, etc. Standardized evaluation could then be used within the next 6 months for justification to continue services, although that is not a requirement at present. That is proposed in the new Wyoming Department of Health rule set. And it would be best practice to use standardized evaluations when first determining eligibility using clinical opinion. Oftentimes we get asked, so what is an example of a good clinical opinion used on that eligibility determination page in the IFSP? And these were some excellent statewide examples. These are real examples that were written in your centers. The first one is regarding communications. And I'll read these so that we can just share them together since they're long. Sorry about that. In Bob's communication skills, and names were changed, pardon me. In Bob's communication skills, based on standardized assessment, his receptive and expressive language skills fall within the typical range for a child of his age. However, based on parent report, observations, and clinical judgment, Bob's expressive skills are currently determined to be below the typical range for a child his age. Bob's expressive language consists of approximately 5 words with a limited consonant inventory. Bob has difficulty imitating words, and he is not combining words. Based on clinical opinion, Bob would benefit from speech-language therapy to strengthen his current expressive language skills and to increase his vocabulary. Sorry about that, I was one ahead. The second one would be, Sally demonstrates fine and gross motor skills on standardized assessments that are within typical range for her age. However, this testing demonstrates skills that are below her age level and a scattering of skills that are above her age level. Observation and parent report determine that Sally demonstrates skills below her peers. This may be due to high muscle tone that makes activities of daily living such as self-feeding, dressing, toileting, and play difficult for her to manage independently. Sally's quality of movement and skill are dependent on high muscle tone. Based on clinical opinions, Sally and her family would benefit from PT and OT to help her be as independent as possible with her activities of daily living, such as beginning self-cares, self-feeding, and play. As you can see, these two real-life statewide clinical opinion pieces are very rich in description, specifically describing that child and family and what their needs are. We've all assessed a child who may not be determined eligible just on the assessment alone, but we clinically see things that are strikingly non-typical. Now we'll get on to this one. Sorry about the advancement of the slide. After we've determined that area of eligibility, next we're going to be talking about just the timelines of developing the IFSP. An IFSP must be written within the family within 45 days of referral. Assessment for eligibility, including the diagnostic assessment, interviews, and observations, are completed within that 45-day time frame. Those are calendar days. And a referral occurs when either the date that a child fails a screening or the date that the physician, friend, parent, community member notifies the CDC of the referral. That can happen via text, phone call, or conversation.
So we're going to continue to talk about developing the IFSP, and what is important for you to realize after the 45 days is what should that IFSP look like as you get ready to sit down and put that together. Sorry about that. The first thing that is critical is that parent input must be evident within this story. In order to have a well-established IFSP, you need to have the parent input into this. Parent can be used for biological mother, father, foster parents, could be a grandparent raising that child. You need to be sure that whoever is the primary caregiver for that child, that their input is relevant in this story for the child. You also need to determine where your IFSP will be occurring and provide prior written notice. This needs to be on your priorities and concerns page, your objectives, your strategies, and a copy of the RBI or interview. Your RBI and your parent interview should really be matching together. You really need to look at doing these 3 steps. Ask open-ended questions. This gives parents an opportunity to talk and express the things that they're seeing, the things that they're experiencing. If you're asking just yes/no questions, you're going to miss out on a lot of critical information. The next step that you need to always look at is affirm their feelings. Sometimes you might be the first person who is delivering information to them that their child is delayed, that there's something going on with their child. Again, not easy to hear at any time, but especially the first time. So they might be experiencing a wide array of feelings, such as denial, and you need to help them work through that. It might be fear. You just really need to affirm their feelings as you're talking through the story of their child. And thirdly, you need to educate them. That is one of the biggest roles of Our job working in a child development center is educating families of what this means to have eligibility, what is going on with their child, what things they can expect, what resources are available to them in their community to help support them in all areas. The only thing going on for them probably is not just the delay of their child. So it's really educating them on everything that they need to be able to handle as a family to help this child move through development the best way possible. And you should really be utilizing these steps each time that you're getting parental input. When you're developing the IFSP, you need to be sure that there is an invitation to the meeting and really determining with your team who should come. You need to know who is relevant in that child's life. If that child is in child care for 8 to 10 hours a day, it's pretty relevant that that child care provider should have some input into the IFSP because they are spending the majority of their time, especially their awake hours, with that provider, and they might have input that is different than anybody else who's working with that child. You need to be mindful if they're in the child welfare system. Is there foster parents? Are there the biological parents? Are there grandparents who are raising that individual? All of those people need to be considered. You also need to consider, are they receiving any services outside of the Child Development Center? Is there a therapist at the hospital? Is there another therapist who's coming into their home? They are part of the team, and you all need to be sure that you're on the same page for this child and family, or it's very confusing for families and very unfair for them to not be working together as a team. We also need to look at that, are the child's needs met in the areas of eligibility and all other areas of child and family concerns. So making sure that their eligibility is being addressed, and as Sarah had mentioned earlier, your ticket is punched. So if there's some other issues that need to be addressed but not necessarily scored in your eligibility area, they can still be part of your IFSP, and you need to make sure that they are captured in this document and that they are addressed. You need to cross-check your areas of eligibility by looking at your Z-score and your percent delay in the developmental areas and ensure that they are on your eligibility determination page. Also, where objectives are identified for all areas of need, might be multidisciplinary is okay. Combining, you might be looking at different examples of feeding, looking at behavioral, motor, communication, really addressing that you are getting all of the needs met for this individual child, and that these are child-centered. Really, we should be looking at how is this child going to accomplish this, and is this built in so that this is a child-centered goal and a child-centered IFSP as you move this forward. Okay. So now that we've developed this IFSP, now what? And one thing that I want to say back from the previous slide that I forgot to mention is that if a child is having some consultation services, if you're using a one-person approach in the home and you need a consultant on there, say a speech-language pathologist, that speech-language pathologist needs to have eyes on that child at some point in time. It is an impossible task to ask somebody to consult on a child that they have not laid eyes on and have not been able to use their professional judgment when looking at this child to determine their needs. So if you are using that model and you are doing consults, at some point in time that consultant does need to see that child. And so now as we are looking at developing the IFSP, we also need to understand that this is a living document, that this can be changed Typically, we do those at 6-month reviews, but if there is an issue that comes up before that and it needs to be changed prior to the 6-month review, please do so. You do not have to wait for 6 months in order to update an IFSP plan. A child may have had surgery. A child may have had a decline in their function. They may have exceeded your expectations before 6 months. So you need to make sure that you go back into that document when it is most appropriate. But it is a requirement that you review it at least every 6 months. You need to update your objectives. You need to update your service delivery. You need to update medical records, especially if they are eligible under medical diagnosis. You need to update parental concerns and progress. Service that is being delivered needs to be reviewed, and you also need to look at the instructional assessment. That is what you're using as a continual check of your goals and looking back to what you need to do, maybe the same or what you need to do differently as you move into the next 6 months of this IFSP. So the instructional assessment is the process that is necessary to provide your starting point, your continual feedback, and your periodic review of your effectiveness of the intervention that you are providing. You need to be doing constant monitoring of that. If you don't, then you are going to miss the progress or possibly lack of progress that the child is making. And you need to be constantly looking back at how you can either progress to the next thing or readdress what isn't working and approach it differently. It helps you to monitor that over time. And then it also helps you to explain and educate the parents on what you should be seeing next and how you plan to accomplish that. And then also looking at how quickly they are progressing. This is a great educational tool to use with your families as well as doing some own self-reflection and team reflection if there's multiple people working with the child. The instructional assessment yields information about what infants and toddlers know and are able to do at that given point in time. Okay? It also then guides you in those next steps, and this should be located in your file. It can be done through developmental checklists. It could be done formally or informally. The most important thing is that it is documented. You need to ensure that you are constantly monitoring how these children are doing. These are notes that are looking at your progress towards your goals. So your goals should not just be addressed at the 6-month IFSP. It really should be addressed continually to know if you're making progress towards them or not. This can also be done through interviews, through observations, which is critical going back to that IFSP team. If the child is in child care 8 to 10 hours a day, probably pretty important to talk to that provider to see how things are progressing on a regular basis with that provider. Also, talking with the parents, biological or foster, depending on where that child is. Children may behave differently in different environments, and that's really important for the whole team to know. The instructional assessment provides that foundation for developing that IFSP and that 6-month review then, especially those with that medical diagnosis. So really ensuring that you're going back and looking at those critical points. The best information is collected frequently and used continually to inform intervention and instruction. So making sure that this is done on a regular basis. Infants and toddlers, as you all know, learn very quickly. And if you're not looking at that regularly, you might miss something. Assessment is to inform and monitor that instruction is most accurate if there are multiple sources of information. So again, going back to that, ensuring that you're asking and interviewing the people that are important in that IFSP team, and that also in your own team and for your own services that you're providing. Methods used to collect this information should be an ongoing intervention and interactions of the home environment. So also documenting what is going on around that child. As we talked about, if they're in child care, if they have a foster home and they're doing visits with the biological parents, making sure that you're documenting those interactions because they might look different, and that might help guide you of how your interaction needs to be with those individuals. Maybe you need to give more support and education in the child care setting, or maybe with the biological parent. So really making sure that you're documenting that to know where you need to provide those supports. Assessment instruments should be criterion reference with items that reflect functional skills. The results are being used to develop your plan and monitor your progress, and there is data available to document the reliability and validity. This, again, should be in the working file for you. Can be done through those checklists, can be done through data tables, can be done through narratives. You just need to ensure that it is being documented. Instructional assessment instruments and procedures, again, must be culturally and linguistically relevant. So ensuring that as you're assessing this, that you are taking all those things into account. So children who are receiving additional help, they can't afford to spend instructional time or everyday learning on goals that are just too busy or too difficult. So by constantly going back and monitoring, you can ensure that those goals are functionally relevant, that they are going to be able to progress in, so that you're not just giving busy work to a family. You must reflect that real progress rather than giving inconsistent administration or scoring or interpretation. So it's really important that you know that child and that you are talking with the individuals who know that child well too. So when you look at the instructional assessments, what questions are you really answering? And that is, what are the child's unique developmental and early learning strengths and needs? What are appropriate goals and outcomes for that child? Okay. We often can focus on just what are the child's needs when we're developing ISSPs, but it really is important to look at what are the strengths so that you can build off of those to help meet their needs. So ensuring that you're answering that question both for strengths and needs. What results are you getting from that? You're getting formative data. You're getting their present level. You're helping to develop your ISSP. You're looking at skills checklists, and you're getting progress towards your goals and documenting that. They are criterion reference. Okay, so they're curriculum and developmentally based measures. They are looking at all your areas of development. Who administers this is teachers, paraprofessionals, your specialists, parents. So really looking at your whole team can be administering this instructional assessment. Okay? And that you really need to be mindful that this is functional and individualized. So some examples of the instructional assessments is the Hawaii Early Learning Profile called the HELP, High Scope Infant Toddler Core, the Early Learning Accomplishment Profile, the EIEP, and Rossetti Infant Toddler Language Scale. Those are just some of the examples that you can use for assessment tools in this area.
If we're getting close to the end, but if you need a bathroom or snack break, now would be a good time to pause and come right back. And we'll resume. When we're teaming for the IFSP, it's important that when you sit down for the IFSP, that you have the team who conducted the assessments and the interviews and the observations to be present when possible. It's also important to have the actual team that will be providing the intervention with that family. Of course, the family service coordinator and the therapist or others. Also on that IFSP, it's important to have other care providers, including community providers, private therapists, social workers, caseworkers, and anyone else who will work to support the IFSP. And of course, parents and caregivers including foster parents. And if you can have both parents and foster parents sitting at the same table, then that would be most awesome for that child. So once we've done the assessment, that information really helps lead us down the path to outcomes and then intervention. The assessment can promote the IFSP development. When we take our diagnostic and the ongoing instructional assessment, it should really be reflected in the goals, the outcomes, the objectives, strategies for that child within the IFSP. It needs to reflect the parent input in the outcomes and strategies. It needs to reflect parent input, and that can be derived from the RBI or from the Parents and Concerns page, the Strengths and Concerns. Good assessment should reflect inside the IFSP and include the standardized diagnostic assessment, again the RBI, the observation of the child, and that ongoing instructional parent assessment. Was there a match or mismatch between the concerns of the parent and what the team found through observation and diagnostic assessment? Meaning, was the parent's concern that the child didn't talk, but the team's concern is that the child didn't walk, in which case you can really incorporate those two together once the child meets eligibility. And that's a good place. Also, if there's a mismatch between what the family sees as the child's needs and what the team sees, that's a good place to make a family outcome to help educate the family on the needs of their child. Where do we find the parent concerns in Cs and in the IFSP? We look to the documentation inside the RBI. We look to the prior written notice, and we look to the priorities and concerns page. And all of those should mirror each other. You may have heard this one before. Writing an outcome can be SMART. It is a goal or an outcome is SMART. Clear, concise, tangible. What, when, who, where, why. It's measurable. Looking at time, especially with our kids, over time. It's achievable. The child should be able to meet that objective. It's just the Goldilocks challenge. Not too easy, not too hard. It's relevant. Goals should be consistent with other long-term goals. And it's time-bound. It should be achieved in a reasonable amount of time. We use all of our information to develop outcomes and strategies. Start with the parents' and caregivers' priorities about the child's learning, their development, and the family's needs. Consider what's working and what's challenging in everyday routines and activities. This may have been a question that you asked within a routines-based interview. And consider how the child's developmental skills, needs, and disability influence that child's learning and participation in everyday routines and activities. The information that we're providing here on outcomes is somewhat limited in scope in this presentation. We will provide another webinar similar to this format on developing and writing high-quality outcomes and strategies this spring. Be sure to join us for that training to assist your center's skill in writing objectives and strategies. So what is the relationship of outcomes and strategies to placement of services? Remember that first, you develop the IFSP outcomes and strategies based on that functional, authentic assessment information. And then you determine places and support based on what's necessary to meet those outcomes. The services a child needs to receive should be based on the outcome or goal, not the other way around. Placement or location of services should be based on whether or not the outcome or goal can be met in the most natural environment. So when we're looking at IFSP outcomes, we really ask a family, what would your family like to see happen for your child? And separately, what would your family like to see happen for your family? That can really lead to two types of outcomes that we see in the IFSP. a child outcome, and a family outcome. When we look at child outcomes, there are really two types of outcomes that you can be considering: a participation-based outcome and a routine activity-based outcome. Child outcomes should enhance learning through functional participation in everyday activities as the child is the learner. They should be important and meaningful to families and caregivers. That's their priority. They should expand activity settings so that a child can be competent in many different places, and should be based on that child's interests. Often, IFSP child outcome statements are participation-based, focusing on the child's interests and assets that will provide opportunities for learning and development. Other times, IFSP outcome statements focus on the routines and activities that parents want or that they need to go more smoothly, such as mealtime or bedtime routines. Next, we look at family outcomes, and there's really two types of family outcomes: participation-based and resource-based. Family outcomes should really enhance the capacity of a family, should support that family in accessing community resources and support, and this may be supported by your family service coordinator. Family outcomes need to be important and meaningful to the family and based on their interests. An example of a participation-based family outcome is Frank and Tara would like to be comfortable in taking Timmy and his siblings to their grandmother's house. An example of a resource-based family outcome might be Jerry will find childcare with her son within 25 miles of her new job. These are absolutely relevant for family outcomes.
So then, as we have looked at the outcomes, then the final thing is to look at intervention and service provision. So often we say more is better. What does that really mean? What does not necessarily mean more services. What it means is more learning opportunities. We know that children need repetition in order to learn, and we know that if we load services, that is not necessarily how they will learn, but providing more learning opportunities throughout the day. All services should be purposeful and necessary to achieve the functional outcomes. So learning is what happens between the professional's contact with the child and family. This should be embedded throughout the child's day. It should be in everyday routines and activities. Should be through multiple repetitions and lots of practice. And the way all children learn and participate with families and friends in their communities. So again, services through the IFSP, through the specialists in your center, are going to be limited. But we know that in order for that child to accomplish the goals that have been set in the IFSP, is that family is going to need to be able to follow through with what has been tasked of them, and it's going to be most easily accomplished if it's embedded into their daily activities, and then that becomes more functional for that child as well. So when we look at intervention and the service provision, we need to look at who is going to be delivering that. So you're looking at, in your centers, you have highly qualified staff. When we look at that, we also need to be very mindful that those qualified staff have a scope of practice that they need to work within. So if you're going to say speech therapy, that is provided by an SLP. Physical therapy is provided by a PT, etc. As you look at that. So a speech language therapy assistant, an SLPA, or a certified occupational therapy assistant, a CODA, that is also appropriate for service provision, but they require oversight and documentation of that oversight. And that needs to be done based on your state rules and regulations under your speech-language license and your occupational therapy license. And that documentation requirement is different for the different disciplines. Consultation can also be provided by other disciplines if only one provider is in the home, which we talked about earlier. That needs to be documented on your service provisions page of the IFSP. It could be a consult 10 minutes with an SLP, but again, as we said before, at some point in time, that consulting service needs to have eyes on the child in order for that consultative service to be meaningful. Early interventionist is not a discipline that is recognized in Wyoming, so that should not be on your service delivery page. And who provides special instruction? When we look at that as a provision, all disciplines can provide special instruction. So anyone can be listed under special instruction on the IFSP. And so as you are beginning to look at eligibility and your service provisions that will be on your IFSP, the most important thing to consider is all of these beautiful faces that you see here. It really is all about the children and how you're going to be able to work with them and their families to help them accomplish their goals. And so part of this information was taken from the Early Childhood Technical Assistance Center. So we want to give credit to them in our presentation. And then since we did this as a web-based recording, this is a web module, and there will be a live question and answer session with myself, Sarah, and Christine this Friday, March 17th at 12 p.m. So please plan to attend if you have some questions based on the information around determining eligibility. If you have additional questions, you can contact Christine Demers, and her phone number is listed there. And then you will also be doing an online assessment and looking at the eligibility for the STARS credit, and you'll receive a certificate of attendance. And I am going to go ahead and turn it back to Christine to give you any last-minute information.
All right, thank you, Sarah and Jen. What a wonderful PowerPoint, and I appreciate all the wonderful information that you put into this training. Very important that I wanted to emphasize two things that they did talk about was the authentic assessment of a child. That is very important, that you are getting the authentic skills that this child has, and that you are effectively assessing the child's needs for their services. I also want to emphasize that you are correctly identifying the eligibility area that this child meets when you are determining whether or not the child is determining eligibility, is that you are using the developmental assessment as your area for eligibility, that you are using the medical diagnosis that has a high probability and that you're correctly identifying that, or if you are using clinical opinion, that you are correctly identifying that you have used clinical opinion and you are including that rich description of why the clinical opinion is being used for eligibility. And that will all be on your eligibility page, and that you are only marking one of those areas for eligibility. If you have any questions or would like to have more information on anything in these slides, please contact me at christine.demers at wyo.gov. Christine.demers at wyo.gov. Thank you. This concludes our training.